shed some light on some of the studies that you found most interesting at the ESMO 2017 Congress, in particular about unmet need or brain CNS cancer?
So there has been a number of studies presented at this year's ESMO that are of value to the everyday practicing clinician in looking after patients with lung cancer. And one area in particular that is an increasing problem is in patients who have ALK-positive non-small cell lung cancer. And these patients are quite a minority of all patients with lung cancer, but they have an increased risk of brain metastases and have at present treatments that will help for often some years, but the current treatments are often less effective when the cancer has spread to the brain.
Thank you. Can I ask you, is it the ALK status that makes them more susceptible to brain metastases?
That's a good question. We don't really know. It might be that that is part of it, the biology of these lung cancers, but also probably because the current treatments do control the disease for longer than the disease can be controlled in patients with different types of lung cancer. And as time goes on, the spread to the brain then becomes an escape mechanism for that longer disease control.
Thank you. So which trials did you see today that were of interest to this particular population?
So there were two studies in particular that were both of a new drug called alectinib that has previously been reported on. Alectinib was previously demonstrated to be superior to a current standard of care, crizotinib, in first-line treatment. And the focus of today's study was on alectinib's efficacy against brain metastases. And the results are extremely important to us because this study, compared to others, monitored for brain metastases rigorously through the course of the study. So we were able to see the evidence for response in the brain and also progression in the brain at pre-specified time points, and patients randomized to either alectinib or crizotinib underwent rigorous brain imaging. And that has not always been the case in other studies. So the result of this trial showed alectinib to be superior for treatment of brain metastases, and gives us a good evidence base now for our everyday clinical practice.
Is that the results of the ALEX and the ALUR combined?
So they're the results of the ALEX trial, the subgroup analysis for first-line treatment and efficacy against brain metastases. Another study, the ALUR trial, compared alectinib to chemotherapy in the second-line setting in patients who had all previously received an ALK inhibitor with crizotinib. And again, the CNS efficacy was one of the endpoints of the ALUR trial, again showing better efficacy for alectinib compared to chemotherapy.
Will these be practice-changing trials, or are they just confirming what physicians are already doing?
Well, particularly in the UK, we can't yet give alectinib as a standard of care, so they are going to inform our practice. We would hope to obtain availability of alectinib for our patients in the UK. It's available elsewhere in the world. And what we are now looking forward to is being able to have a menu of different ALK inhibitors for our patients with ALK-positive lung cancer, and ideally be able to select the most appropriate type for that patient's pattern of disease. So for a patient who has brain metastases when newly diagnosed, which is relatively common, alectinib would be the preferred agent compared to crizotinib on the basis of the data we've seen today.
Thank you. What other studies have you seen or posters have you seen that have caught your attention this week?
Another large area of unmet need is for patients with small cell lung cancer. And this accounts for about 15% of all lung cancers. It is very sensitive to chemotherapy and radiotherapy, but in most patients it comes back after initial treatment such that survival is on average less than 1 year. And for the past 3 decades it has been very difficult to break through with another better therapy for these patients. So there was one interesting abstract that was presented today on an agent called Lurbinectedin. It's a DNA damaging agent and also has some activity around DNA damage response and the tumour microenvironment. It may modulate how tumour macrophages react. And there is data suggesting that as a single agent even, the response may be around 35% or so in patients who have previously received chemotherapy. And that certainly is better than the around 10% response rate that we see with our current standard of care second-line chemotherapy. So that is an agent that is, I think, one to look out for in ongoing studies. It does have some toxicities which are of concern because for these patients the emphasis is on palliative therapy to enhance quality of life and not just length of life. So there will need to be scrutiny as the trials evolve of how the toxicities are managed. There's another study for an extremely rare subgroup of patients who have had EGFR mutant non-small cell lung cancer treated and who then develop resistance with transformation to small cell lung cancer. And because it is relatively rare, we don't have any evidence base to draw on for the best way to then treat the small cell cancer when it occurs. And a very nice study conducted in the States has collected 16 cases over 10 years, which tells you how rare this is, but extremely important, and it shows that, or suggests, even with that small number of patients, that transformed small cell lung cancer responds to chemotherapy and should be treated really in a similar way to how we treat the everyday small cell lung cancer that we see in patients who haven't previously been treated for EGFR-positive lung cancer.
Is this transformation associated with the EGFR inhibitor therapy, or is it something that happens in non-small cell cancer patients anyway?
It's a mechanism of resistance. So the commonest mechanism of resistance is development of the T790M mutation. And that is where osimertinib, third generation TKI, has been indicated and is effective. But for 50% of patients, there is a different mechanism of resistance. And Dr. Sequist and colleagues published in 2011 a series of 37 patients where 14% of those had a transformation to small cell. And that was really quite surprising because small cell lung cancer is strongly associated with tobacco smoking in its etiology, whereas EGFR-positive non-small cell lung cancer is associated with a light smoking or a never smoking history. So it has emerged from the abstract presented today that the genetics of this transformed small cell are very similar to small cell in general. And And so really quite interesting and important, because these cases are rare in our everyday practice. We need some evidence base in order to counsel a patient about what can and can't be done.